Hi, Learning Plan 3 is all about anti-infectives. Now, anti-infective is an accurate label, but it's very broad, and it's not at all specific, and I like dealing with specifics. Anti-infective covers things that stop infections, right? Anti-infective. But a lot of things can cause infections, and we're going to treat them differently if it's a virus or bacteria or protozoa or fungus. Different agents cause the infection, so we have to use different type of anti-infectives. That's almost like saying, I'm going to have meat for supper. Or is that what you say? Or would you say I'm having beef or chicken or pork? You're specific when you talk about food. We're going to be specific when we talk about medicines. All of these are medications that stop infections. How do you know you have an infection? Well, the common ones, fever. And by fever, we mean something over 101.0 Fahrenheit. Pain might be localized to a specific infection, like if you have if you're a child and you scrape your knee and you get infected, it could be painful there. Or you could have an infection that causes generalized aches. Fatigue, weight loss, pus. Again, that would be a localized infection, usually a surface infection, but you can have internal infections like that, and those are really disgusting. Redness, or rubor, R-U-B-O-R. It means an area of the skin that is red. Rashing, itching, hives, joint pain, wheezing. These are all symptoms, and you're not going to get all of them necessarily, but these are things to watch out for. So when you're talking about anti-infectives as a whole, we're going to talk about three other layers to get more specific. There's the therapeutic class, and these are drugs that have all the same intended purpose or therapeutic effect. Then there's a pharmacological class. Now, this is a different way of looking at medications. These are grouped together in similar chemical composition. So therapeutic, they have the same effects or same therapy. Pharmacological have similar chemical structures. So because they have similar structures, they're going to probably have similar effects. Here's a non-anti-infective example of Prilosec and Nexium. They have the same base chemical, but with a different added ion to it, which makes it a different medication, but it's essentially the same active ingredient. So those are pharmacological classes. And then you have the specific individual drug name, and this is the most specific way of identifying a drug. Now we're going to talk about generic names. Remember, generic names are always lowercase letters. And we're going to talk about brand names or trade names, and those are capital letters always. So that's just a way of breaking it down. And when you are in clinicals, your instructor may ask you for the therapeutic class or the pharmacological class, especially when we're talking about antibiotics and anti-infectives as a whole. Now, we're going to be working on these care maps here, and we'll talk about these in class. For every medication, we're going to work on a care map like you see here with the five sections. The pharmacological class or the chemical composition class will be in the middle. For each of these classes, we're going to look at the side effects, contraindications or why you do not take it, any precautions that should be, avoid sunlight, give with food or without food, refrigerate medication. Those are precautions. Patient teachings. Usually precautions will trigger a lot of patient teachings. And then nursing considerations. What do we assess? Nurses always assess. So what would you assess after giving an antibiotic for a day or two? Well, you would probably expect to see all of those symptoms of an infection to start going away. They will not happen immediately. But over a day or two, you should start seeing results. One of the labs that will be affected usually by an infection. Oh, wait, let me back up for a second. Those list of symptoms, those apply to most people. Not everyone gets all those symptoms. Even if, for example, most people would get a fever with influenza, let's say, or a urinary tract infection, UTI, Most people develop fevers. But if you're working with an elderly patient, say a patient over 70 or so, they may not get a fever at all. Just no fever. What they will have is they'll have altered mental status. We'll get ahead of that later, but I want you to understand that those symptoms are not always going to be present, even with the same infectious agent. Similarly, white blood cell counts usually rise with infections, but may not. And that could be affected by underlying diseases in the patients or their simple response pattern. There are types of white blood cells. See, and the white blood cells are what we're looking at for infections. The young neutrophils are bands or stabs. Neutrophils, they have segments in them. They're also called segs. Eosinophils, basophils, lymphocytes, monocytes. When there's an increase in bands and neutrophils, that is an indication of an infection, active. This is the body's first line of defense against a bacterial infection and a severe stress or inflammatory process. When you're studying for your final exams and you are really under stress, your body will start pumping out bands and neutrophils. It assumes that because you're having these chemical changes, these hormonal changes, the cortisol released into the bloodstream, it assumes it's under attack, and so it acts as though it's under attack. So this when you need to understand how to read a WBC. When you get your lab results, if the doctor orders a CBC with differential or with diff, is how it's said, they're going to ask for a complete blood count, and then they want to have a breakdown of every category of white blood cells. We'll talk about that again also. Now, when you get the total WBC count or white blood cell count, I'm going to use WBC from this point forward. The total count should be 4,500 to 11,000 in a cubic millimeter of blood. And that's an absolute count. And it is actually counted. I remember in high school, I used to have to count underneath a microscope, and that's really painstaking. Now there are machines that do it very quickly. But then they look at a percentage of all those different subcategories. And if one is up or down, that will indicate maybe it's bacterial or viral or allergic. I mean, an allergy attack will cause some of your white blood cell counts to go up. Antibiotics. Now, in the best of all possible worlds, and of course this does not happen all the time, but in the best possible worlds, before you start the antibiotics, you would want to get a culture, especially if the culture is like surface. If you have an infection deep internal, appendicitis, hard to get a culture there, okay, until they do the surgery. But if you have cellulitis, you scraped your leg and now you have this diffuse rubor of the skin around that wound, that could be cellulitis. The doctor may want to take a swab and get some of that pussy material and culture it to find out exactly what's causing it. Just as when we compare meat or chicken, pork, beef, there's bacteria, but then there's strep and staph and Klebsiella and Pseudomonas, and each of those are handled differently. So that's very important. Antibiotics only treat bacterial infections. If you have a viral infection, an antibiotic is worse than useless. Not only will it not kill the virus, it will potentially make you sicker, could leave you open to called a superinfection called Clostridium difficile, or C. diff. And this is how antibiotic-resistant organisms are developed. So, viral infections, if you have a child and you think they got a head cold and you take him to the doctor and he goes, it's a virus, don't ask them for an antibiotic. Just don't. Now, different types of bacteria are classified different ways. There's a stain, remember from microbiology, the gram stain. Gram positive means it picks up the gram stain. Gram negative, it doesn't. Shapes, cocci, bacilli, spirilla. And do they live in or out of oxygen? Are they aerobic or anaerobic? all of these different characteristics will drive what type of antibiotic the doctor will use. When the doctor knows, well, you never know exactly, but when the doctor has strong suspicions based on evidence of what the causative agent is, those infections are much easier to treat, or at least much more efficient to treat. So antibiotic therapy, there's two types of antibiotic therapies. There's empiric and there's prophylactic. And let's do prophylactic first. Sometimes people need antibiotics prior to procedures. A person who has a heart valve, an artificial heart valve, will almost always need an antibiotic prior to dental cleaning or dental surgery, or even filling a cavity, because there's a risk of oral bacteria from the oral cavity getting into the bloodstream and migrating to the heart. So they take an antibiotic in advance, a prophylactic antibiotic, which is a preventative to prevent that infection from even taking root. Surgeries, abdominal surgeries or joint surgeries, almost always before surgery, they will give an IV antibiotic as a prophylactic to help prevent postoperative infections. So when they give prophylactic therapy, there is no infection yet, and they want to keep it that way. Empiric therapy is based on evidence. When you have empirical evidence, it means you have physical evidence that you can see or touch or feel or whatever, that it's there. So you may have the culture, you may have all these other evidence like the redness, the pus, the swelling, the heat, the pain, the fever. That would be empiric evidence that there's an infection. So when an infection already is there, then it will be treated empirically based on that evidence. Now, when that just says that there's an infection there, and generally that will be treated with broad-spectrum antibiotics, which means broad spectrum covers a lot of things. If you get a culture and that comes back, then they're going to go to narrow-spectrum antibiotics, and that's no longer empiric therapy. That's focused therapy. That is narrow-spectrum, meaning they're giving you a medication that targets that one bacteria. It's much safer because when you give a broad-spectrum therapy, it can kill off a lot of bacteria, including the good bacteria that live in your gut, and you want those. Narrow-spectrum targets the one specific antibiotic. Now, there's therapeutic response and subtherapeutic response. Therapeutic response suggests when after you start the medication that there is a reduction in the signs and symptoms. So the fever goes down, pain goes away, the redness starts going away, the pus stops forming, the WBC count starts going down. That's a therapeutic response. It's measurable. If you have that cellulitis and there's a red area, very commonly you'll take a skin pen and on day one you will put a circle around that red area. And then every day you'll measure it. Is it getting bigger or smaller? If it's getting smaller, therapeutic response. It's getting larger, subtherapeutic. Meaning you're really not seeing any improvement. What could that be? Why would you not see improvement? Wrong antibiotic is commonly it. If you have a bacteria that's resistant to something and you're giving it, it's not going to work. Or you're not giving enough of it. There are times when a person needs simply more medicine. Remember we talked about that minimum effective concentration? This is called, with antibiotics, it's called minimum inhibitory concentration. So the minimum amount of medication in the bloodstream to stop growth. So therapeutic response, you're seeing a reduction of symptoms. Subtherapeutic, no change or worsening. Now I talked earlier about antibiotic resistance, and this is a growing concern. The most common bacteria that's antibiotic resistant is Staph aureus, specifically methicillin-resistant Staph aureus, or MRSA, which in health lingo is pronounced MRSA. Another one is VRE, which is vancomycin-resistant Enterococcus. That's bad. Vancomycin is one of the big broad-spectrum antibiotics. It is powerful, and now we have bacteria that are resistant to that. Staph aureus, which is found on the skin, it's an aerobic bacteria. We all have it on our skin, but some people develop problems with it when they get a scratch or a cut. MRSA is still relatively easy to treat. It's resistant to the penicillin or the methicillin class of medications. So that means all those cillins are no longer useful. But we have all the cephalosporins, and we have the erythromycins, and we have all these other medications that still work. VRE is vancomycin resistant, and there's not many things after vancomycin. More than 50% of hospital-acquired staph infections are MRSA. What that means is when you're dealing with a person who has a MRSA infection, you need to gown up and protect yourself and the other people that you're treating. MRSA is very easy to spread. It's not necessarily easy to catch an infection, but it's very easy to become colonized. And more often, when people from nursing homes are admitted to hospitals, especially if they go to intensive care, they will be tested for MRSA to see if they're carrying MRSA, so that they can protect everybody else around them. So if a patient is infected with VRE or MRSA, they will show all the classic signs of infections: fever, redness and swelling if it's localized on the surface, aches, fatigue, weight loss, no appetite called anorexia. That's if they're infected. If they're colonized, there's no symptoms because they're not ill yet. Colonization is simply there are bacteria growing on or in this person, but there's no longer either enough to cause an illness or it's not a break in the skin to get in and cause illness. Colonization can lead to infection, but it's not necessary. So how do we fight antibiotic resistance? Well, vaccinate people. If people are vaccinated, they're less likely to get ill and less likely to need treatment. Prevent conditions that lead to infections. So in other words, gown up if your patient has MRSA. Properly scrub with the correct cleansing agents. If you're dealing with MRSA, an alcohol wash works fine. If you're dealing with C. diff, you have to use soap and water because alcohol doesn't kill C. diff. So know how to prevent infections. Get any equipment that is not necessary in the room out of the room. The more equipment in the room, the more sources that can become contaminated, and if it's not properly cleaned, spread the germs. As I said before, know when to not ask for an antibiotic, both for you and your patient. Teach your patients. If they think they need an antibiotic and they have all the symptoms of a viral infection, teach them the difference. Only treat infections, except for when a person needs a prophylactic antibiotic. Otherwise, if you go to your doctor and I think I've got a sinus infection, I better get something, your doctor should not be giving you anything unless there are signs of an infection. As soon as possible, stop any antibacterial treatment or any antimicrobial treatment at all. But complete the full course of treatment. So if the doctor prescribes 10 days, take all 10 days. Don't go beyond. And don't take partial doses and stretch out because that will create a stronger bacteria. And hand hygiene. Perform hand hygiene. Oh, something else. Perform hand hygiene. Wash your hands. It's amazing how many people don't wash their hands, and seriously, that's disgusting. So wash your hands. That is the single most effective way of preventing an infection. Now, MRSA. Remember we talked about MRSA being methicillin-resistant Staph aureus. Usually they're going to go right to vancomycin because that is a powerful antibiotic and it takes care of severe staph infections. It takes care of other gram-positive infections, such as C. diff, Clostridium difficile. Now, we got to be careful with this medication. If a person has renal dysfunction, remember kidney dysfunction, and what do we mean by dysfunction? Bad functioning. Or hearing loss, vancomycin can worsen it. Elderly and neonates, so the very old and the very young, do not tolerate this very well. There's a very low therapeutic index. Remember, therapeutic index means the minimum effective concentration, and then up here it's toxic. It's a very narrow window to work with. It's nephrotoxic and ototoxic. Nephrotoxic, well, first off, toxic, poisoned. Nephro, kidney. So poison the kidney, and ototoxicity, ears. It will affect the kidneys and the ears, and there's something called red man syndrome. Tell me what red man syndrome is on Monday, okay? There's other antibiotics that can be used to fight antimicrobial resistance. To be totally honest, I've never given these, ever. Sinucid, quinapristine, and dalfapristine, okay? Zyvox, oh, I have given Zyvox a couple of times. And then Cubicin, never given that. Those are very new, very expensive, and used when vancomycin just doesn't work anymore, or when vancomycin is too dangerous. This segment is now at almost 22 minutes. I'm going to stop. We're going to pick up in part 2 in just a moment.